I'm very happy to be invited to this wonderful meeting in Ha Long Bay in Vietnam. I'd like to thank you, Dr. Tong, for inviting me to this meeting. And the first session is about abdominal intervention. And I'm very happy to chair this meeting with Professor Tong. I'd like to introduce the first speaker, Dr. Wang Junjie from China. Today he will talk about innovation and practices of radioactive seed brachytherapy in China. As you know, radioactive seed implantation very popular in China. Please welcome him.
And this my there no change. It's wrong. Press wish. Oh, thank you. And thank you so much for your invitation. And this is the first time for me to come to Vietnam and Ha Long. It's a very beautiful city. And today I'd like to introduce briefly about the seed implantation in China. This cannot work. Sorry? It cannot work. Oh, this here. It's history. You know, the brachytherapy play very, very important role. No sensitivity. Yes. And this is a great scientist who invented the radium. From then on, the brachytherapy became a very important modality for anti-cancer. And maybe 100 years ago, and radiology and radiation oncologist and nuclear medicine doctor, we belong to one department, and then they divided. Even at present in China, the three modalities belong one department too. Some hospital, but most of them have divided to different disciplinary. So maybe last century, the ultrasound get into the field of the brachytherapy, and let this brachytherapy more precision and accurate. And then another 20 years later, the 3D conformal radiotherapy get into this field. Will let the seeds more accurately located in the tumor. So, press this one, okay? This might more fast, yes. And at present, the brachytherapy has realized what? More precision and ablation. This is a key point modality of brachytherapy. HDR and the 2 isotope, Radium-125 and Palladium-103, and the CT guidance and 3D printing modality. But the last two modality occur in China. And this is the criteria for early stage prostate carcinoma. We done this cases 18 years ago, in year 2001. And we cooperated with a urologist, ultrasound doctor, we get together. And then we transfer to the other part from the next year, in year 2002, just because we guess if the seed implantation can treat prostate carcinoma, but also should be treat the other solid carcinoma, the pancreas carcinoma, You can see we use ultrasound. This is maybe just 1 month later. The tumor realized completely response. And there is another pancreas carcinoma patient. You can see this patient does not receive further external beam radiotherapy. And this patient survival 2.5 years. So this is our preliminary result. What we have received, the tumor response rate was nearly 80%. So I think this is a very, very good modality. You can see the young guy, just 4 years old. He suffered from the cholangiocarcinoma and received surgery, external beam radiotherapy, and more than 20 courses of chemotherapy. But was still recurrence. After 10 years later, he go to school. This ultrasound, and in year 2012, we connected with the TPS with CT simulator. The product was designed by ourselves, and at the same time, they edited the Chinese expert consensus about the CT guidance in China. And we published a series of papers about the CT guidance. But it is spent 15 years up to that time. This modality cannot become a standard procedure. Why? Just because the different doctors have the different skill, have the different ability to puncture. So we cannot keep every cases at the high level of QA and QC. So what we should do? This is a serious image guidance in China. Ultrasound, CT, MRI. But MRI cannot very popular at present. That's because the price is very heavy, is very high. So the CT become mainly modality in China. This is for prostate HDR. So they give us a lot of suggestions. This is indication for HDR. That's 5 diseases: prostate, skin, and breast, and cervical and uterine carcinoma. This is another Chinese doctor team. They combined the stent with cyst for esophagus carcinoma. I hear about a lot of patients of esophagus carcinoma in Yunnan. Maybe the same situation in China too. So what we can do? Just stent with cyst can have the expanded function, at the same time can kill cancer cell. So they published a series of high-level papers, even the licensed oncology. So this research program has received the high prize in European Society of Radiology. In year 2015, another techniques occur about material additive manufacturing. What's the meaning? Just because all the material get into the machine and will become a solution, and then spread out the layer and by layer, so it become another substance. It's very similar with before you design. So this is the first surgery in our hospital. She printed the spinal cord and implanted it into the patient's body. He's the first case all around China too. I invited him to go to our department and give us a lecture about the 3D printing technology. So we began to design the first generation, the second, and the third one. After the third one, the template became individual and coordinate. And at the same time, we designed the prostate template, the second and the third one. The third one became the multiple functional template. What's the meaning? I will show next. You can see the series template for microwave, for biopsy, for gold medal, and FAR, and so on. And at the same time, I give this modality a definition and publish the paper in the English journal. At the same time, we set up the protocol. There are just 8 steps. You can finish this operation. How we can do? The basic requirement is CT and stabilization and anesthesia equipment and so on. And it is better to connect your TBS with CT simulator. And this is recurrent soft tissue carcinoma are located behind of the eye. You can see the green line is the needle track. You design, doctor design, and the physicist design get together. After you design, and then send your message to the printer. The printer printed the template, and then reset up, and then puncture. And this just keys, very easy to movement. So, need whole body anesthesia. And after the needle get into the tumor, and then implant the seeds. And then, after seed implantation, give the patient another CT scan. You can see the seeds distribute in the tumor. Very, very follow up the pre-plan completely. The 3 months later. This is before seed implantation. It's 3 months later. What do you have achieved? Completely response. Another girl, you can see the tumor. It cannot open her eye. Received surgery, external beam radiotherapy too. 3 months later, and 6 months later, what will have achieved? Not only the tumor reach CR, but also the function, the sensing function conserved. At the same time, we published a serial paper about the dosimetry result. This is the conclusion for the head and neck recurrence disease. And this is a preliminary result of our research. This paper I sent to the English journal. You can see the maiden LC, nearly 18 months. It's much better than the other modality at present. Of course, we will do randomized multiple center research next. And this is the toxicity. There are no more than 3 grade toxicity. So it's a very safety and high efficiency modality. This is another complicated anatomic structure. This is a recurrence after the external beam radiotherapy. You can see the location of the tumor. This is pre-plan. This is real time. You can see the needles distributed in the target. And it's a seed implantation. Oh, sorry, let's do the slides. Yes, the next. 3 months later. 3 months later. Where is the tumor? It's a very complicated cases for this reason. It's about lung carcinoma research. This is a lung metastasis disease before. 3 months later. And this is our preliminary conclusion about the lung. It's adrenal gland metastasis. I received the external beam radiotherapy. My patient came from all around China. They all lost opportunity to further surgery. radiotherapy, target therapy, chemotherapy, and so on. So what we should do, we should create opportunity for patient. So there are no guideline, I think, in clinical work. What is the guideline? Guideline is the patient. The patient is the best guideline. Just because you know guideline in your clinical work. Before, and the needles and the seed implantation. 3 months later, where is tumor? And this is for spinal cord metastasis. This location is very easy. Why? The spinal cord does not move. So you can see needles distribution and the cyst distribution in the tumor. If something like that, don't worry about the outcome. The CR, no any doubt. This is a very deep location of the tumor. You have to penetrate the needles from the front to the back. So not easy to keep the needles straight. What is it can guarantee the direction of the needles? You can see the template. So template is very, very important. You can see the seed implantation and the seed distribution in the tumor. And this is another research about the comparison of pre-plan and post-plan dosimetry parameter for pelvic. So we experienced from the head and neck to pelvic. So I think this is a good modality, just because it can work from head and pelvic. So next we'll continue to further our event. I will do a several case navigator system and the seed strand. It sounds like that. The seed implantation become more precision and more efficiency. What is our aim? The time of seed implantation should be less than 30 minutes. At present, it's nearly 1 hour. So I hold the training program last year, for example, it's just last year. This modality have developed in 1,000 Chinese hospital. And more than 3,000 Chinese doctors receive training program in our hospital. So we further the training. This last year you can see 4 courses. More than 100 Chinese doctors receiving the 3D modality training. So this is a great modality. This is a sentence. The sentence meaning, the conformal radiotherapy came from brachytherapy, and will end it at brachytherapy. Brachytherapy is the soul of radiotherapy. So brachytherapy would be play more and more role in the anti-cancer treatment. Thank you very much.
Thank you, Professor Jie, for your excellent lecture covering the application of seed implantation in various kinds of tumors. Let me introduce the next speaker, Dr. Tan Bien Su from Singapore General Hospital. He's very famous, and I don't think it is necessary to introduce in detail. He will talk about the role of interventional radiology in hemodialysis success.
Thank you very much, Professor Chung, for the kind introduction. I'd like to thank Professor Tong for the very kind invitation to this wonderful meeting of the VSIR. I first came to Vietnam in 1999, visited Chore Hospital, and I can see that the tremendous development in IR in Vietnam is something for us to really look at as an example of how IR can grow. So I'm very glad to be here to share some of our experience in the field of hemodialysis access intervention. Now, there are many roles that interventional radiology can play in a patient with end-stage renal failure requiring hemodialysis. From the very beginning of initiating hemodialysis to maintaining an effective and sustained hemodialysis, and when that access is failing, I think we have a very crucial role in salvaging and re-establishing hemodialysis for the patient. At the very beginning, many of our patients tend to present very acutely requiring hemodialysis, and this is where the interventional radiologist can play a very important role by the insertion of a dialysis catheter. It can be either a non-tunnel or tunnel dialysis catheter depending on the condition of the patient at the time of presentation. And I think there's very good data out there. This is very old data from our center where we reported the initial results of 60 catheters. Interventional radiologists with the imaging guidance have a very high success rate, and especially with tunnel dialysis catheters, there's a very low infection rate because these patients, come back at least 3 times a week, have the catheter handled, they are at risk of catheter infection and blood infection. However, after that, the patient has to decide whether they would prefer peritoneal dialysis or hemodialysis long term. I'm not sure about in Vietnam, but in Singapore, about 80% of the patients elect for hemodialysis. It is actually too high a percentage. I think we should encourage patients to have peritoneal dialysis so they can have the dialysis at home. So unfortunately, if you opt for hemodialysis, then you have to create an arteriovenous access, preferably on the arm, and the preference is to create an arteriovenous fistula rather than an arteriovenous graft, because a fistula can last longer than a graft. Unfortunately, after surgical creation of an arteriovenous fistula, about 40 to 15% do not mature so that they can be used for hemodialysis. However, there are now techniques to help the hemodialysis arteriovenous fistula to mature, and we perform a technique of assisted balloon maturation, right? And we have also recently published our results. Here's an example. This is a radial artery to cephalic vein arteriovenous fistula. After 18 weeks, it was not maturing. So we perform a fistulogram, and you can see from the arrow, let me get the pointer out. You can see that there is a segment of stenosis there. So we can get a catheter through and use a small balloon and gently dilate that segment, right? And to get improved flow through, and then you can wait a few more weeks, and this will get the fistula to mature. From our results of about 100 patients, technical success is quite high, above 95%. Of those that we treated, more than 75% subsequently had their fistula mature, so they were able to get dialysis after we did the balloon maturation. And when we followed up these patients, the primary patency after balloon maturation at 6 months is about 45%. Secondary patency, that means if you go in, if it's failing, you go in and you perform balloon angioplasty again, almost 80% at 6 months. So in the old days, if it did not mature, the surgeon gave up and went and created a new fistula. And if you do that, you start losing the ability of having your veins and your arteries preserved for future dialysis. So the moment there is an arteriovenous fistula created, we try very, very hard to get it working and to get it going for this patient. Now, so what happens after the patient is able to use the fistula? It is well known that over time, because of the trauma at dialysis, they have to go for dialysis and the fistula is traumatized by the needle. The fistula is artificially, because it's actually vein, is subjected to high dynamic flow, right, of arterialized flow, that over time it will fail because stenosis will form. So there are two main techniques we can then perform to maintain or treat malfunctioning dialysis access, and that is angioplasty and stenting. Here's an example. So this is a patient who already was using a radial artery to cephalic arteriovenous fistula, but it was not functioning well. You can see that there's a stenosis at the juxta anastomotic segment, and we come with a retrograde puncture, cross it. Here's the stenosis, and by standard angioplasty techniques, right? First with a 5 mm balloon and then a 6 mm balloon, we can get the stenosis open up and very good flow, and the patient immediately can resume dialysis. Well, this is unpublished results from our center where we looked at more than 800 procedures, and again, interventional radiologists have a very high technical and clinical success rate, very low complication rate with this technique. However, because it goes through repeated trauma, the 12-month primary patency rate is only about 45%, and if you look at the 12-month secondary patency rate, 88%, right? So if you go back, the technical success rate is about 91%, right? So when we perform angioplasty, there's a small proportion of patients, they do not get a good angioplasty result. So we ask ourselves, when we perform angioplasty, the small number of patients, if they do not, respond well to conventional angioplasty, what can we do? And if you look at the literature, there are many, many techniques when you get suboptimal angioplasty that you can tackle. We decided to study two techniques, high pressure balloon angioplasty and cutting balloon angioplasty, right? What is high pressure balloon? It's typically a balloon that is by BART, they are not called BD, and they have a conquest balloon where, because they are made of very strong material, the burst pressure, right, of the balloon is 30 atmospheres. That's a tremendously high burst pressure, right? But of course, it is more expensive. What is a cutting balloon? This is made by Boston Scientific, where they have 3 to 4 longitudinal, effectively they are blades incorporated into the balloon. So when the balloon is inflated, the blades are exposed and the intimal dissection is controlled, rather than the standard angioplasty balloon where the intimal dissection, when we dilate, it is uncontrolled intimal dissection. Okay? When you use this balloon, you have to be very careful. When you inflate the balloon, you do it very slowly. And of course, this is also a very expensive balloon. I think in Asia, we must be very careful about the cost, right, of the equipment that we use, right? It's important that we control the cost of healthcare. So we then did perform a study where for lesions that were resistant to standard balloon angioplasty, we randomized to either cutting balloon or high pressure balloon. And this is the study design. When the patient presented with a malfunctioning fistula, stenosis more than 50%. If there is not a significant stenosis, we do not perform angioplasty, right? But more than 50% standard balloon angioplasty. At that time, the standard balloon burst pressure was 15 atmospheres. Now, if the residual stenosis is less than 30%, that's the end of it, right? The patient goes for hemodialysis. But in those patients where the residual stenosis is more than 30%, we perform the randomization, either high pressure balloon or cutting balloon. And this is what happened. We screened about 500 over patients. 85% of them had a very good result, less than 30% residual stenosis. So they go back for their dialysis. However, there was 77 patients, 15% of this patient population, where the residual stenosis was more than 30%, and we therefore randomized them, 39 of them to a cutting balloon, 38 to a high pressure balloon. And this is our result, that the primary patency of the lesion that we treated at 6 months, superior in the cutting balloon, much better primary patency. Even when we look at secondary patency at 6 months, cutting balloon was also way superior. So what did we conclude from this study? That the majority of the stenosis that we treat, 85% of them, do well with just a standard conventional angioplasty balloon. There's no need for the majority of these patients to use a very expensive balloon or expensive technique, right? However, in that 15% where they do not respond well to standard angioplasty, then this study showed that the cutting balloon is better than a high pressure balloon. Again, we decided to look at another problem in this arena. We found earlier, as I showed you, the 12-month primary patency rate was only 45%. So we asked ourselves, is there a way of improving the primary patency after conventional angioplasty balloon? So we know that the moment we perform angioplasty, we create a vicious cycle to start the intimal hyperplasia again, and the patients therefore will return back with a restenosis. So it is very well known, right? There are drugs that prevent intimal hyperplasia, and paclitaxel is one of them, and there is now technology to coat angioplasty balloon with paclitaxel. So this drug-coated balloon, it acts as a vehicle to deposit the paclitaxel onto the wall of the vessel after angioplasty. We do not use this drug-coated balloon to dilate the lesion, right? It's not meant to be for angioplasty. So we know that there are small studies out published in the literature that suggest that the drug-coated balloon or drug-eluting balloon is superior for primary patency. But also, there was a recent small study from Scandinavia that showed the drug-eluting balloon did not do well. So we performed a randomized trial comparing drug-eluting balloon angioplasty with conventional angioplasty. Right? This was published in Radiology last year, funded by our National Medical Research Council in Singapore. This was an investigator-led, single-center, unblinded, randomized controlled trial. We recruited 119 patients. The drug-eluting balloon that we used was from Medtronic, right? And our primary endpoints was to look at the difference in primary patency at 6 months and also the restenosis rate at 6 months. And this is the trial recruitment diagram. Let me show you. We screened more than 500 patients, and we found that 125 patients were eligible, and 63 was randomized to the DB arm, and 62 to the conventional angioplasty arm, right? And on subsequent follow-up, we analyzed 59 patients in the DB arm and 60 patients in the conventional balloon arm. Right? Here's an example, right? A stenosis in the fistula. Nice result, angioplasty, but this was randomized to the drug-eluting balloon arm, so we treated with the drug-eluting balloon, and this is the final result. And in our trial protocol, they all come back at 6 months for fistulogram. So we have a 6-month fistulogram follow-up, and you look at the lesion, it is still nicely patent at 6 months after DEB. So this is the lesion primary patency at 6 months. You can see, comparing conventional balloon and DEB, superior, statistically significant primary patency at 6 months. The primary patency at 1 year was also superior in the drug-eluting balloon. The circuit primary patency, so is the whole circuit still working, right? Primary patency at 6 months, superior also in the drug-eluting balloon arm, but our circuit primary patency at 1 year, there was no statistical significance. Why? Because in our patient, we have multiple lesions, and in this trial, we only randomize the most severe lesion to the trial. So what does it suggest? That perhaps we may need to treat all the lesions that are significant with drug-eluting balloon, but that would also be very expensive. So what were the study conclusions from this? Lesion primary patency rates significantly improved with drug-eluting balloon at 6 months and 1 year, right? The assisted primary patency rates were also better at 1 year. Restenosis rates were definitely lower, but although there was significant improvement of circuit primary patency at 6 months, this we could not show at 1 year. There are now more trials coming out over this arena. Professor Scott Tarantula, very famous IR in this arena, also at the same time published a big multi-center randomized controlled trial, right? Almost 300 patients. These were his results, courtesy of him. What did they conclude? Unfortunately, in their trial, they did not find statistical significance. They showed that the safety aspect was all right. We know that recently there's a big controversy because of a meta-analysis of drug-eluting balloon in the lower limbs, suggesting that safety is worse with drug-eluting balloon, but we have not seen this for arteriovenous access treatment. So very quickly, let me talk about stents. No, stents should not be routinely used. So when do we use it? Only in elastic stenosis, in an area where you cannot perform surgery, or you use it as a salvage when you have a rupture after angioplasty, or some people believe in a central venous stenosis, if they keep recurring over a short period of time, you can use the stent. Now, if you try and dilate a lesion with an angioplasty balloon and the balloon does not open up completely, that is not a good situation to put a stent in, because the stent will not open up the lesion. Here's an example, a central venous occlusion, left brachial cephalic vein occlusion, long segment. We have to come from the arm, from the femoral approach. We managed to get through, right? Angioplasty, and the result is quite poor, right? So the stent that we like to use is not the wall stent, because in the central vein, with a big wall stent, the shortening is very unpredictable. It is better to use a nitinol stent where we can predict the shortening much better, right? So in this case, we deployed a nitinol stent, angioplasty after the stent was deployed, and here you can get very good flow after stenting. The other area, this is a long segment stenosis of a radial artery to cephalic vein fistula. Perform angioplasty and a very bad rupture, you can see there. So we immediately put up the balloon for balloon tamponade, but it was not good enough. You can see that the rupture is quite a bad rupture, right? So we had to put in a covered stent, right? And this is the, but covered stent and seals the rupture very nicely. Now, the arteriovenous fistula and graft can also suddenly thrombose, and the interventional radiologists also have a big role to play here. There are various techniques for thrombolysis, right? And here's one such technique where we can perform pulse spray thrombolysis and again get the graft going after angioplasty. Okay, here, and if you look at the result, clinical success of these techniques, more than 85%. So, what is very important also for interventional radiologists is for us to get more involved with patient care. So we should be running clinics, going to the wards to review the patients. I know in China, there are leaders in clinical care. Interventional radiologists run their own wards, but in many parts in the rest of the world, I think we are still behind. And I think it's important because this patient will always need to come back to look for you for re-angioplasty, re-intervention. So these are the take-home points for my talk. What are the roles for us in the patient who requires hemodialysis? We have a big role to play in getting the patient start dialysis, maintaining effective and sustained hemodialysis, right? Salvaging and re-establishing hemodialysis with the techniques in angioplasty, thrombolysis. And also it's very important that we lead the research for better care of these patients, and we should actually strive to be the doctor managing the patient with hemodialysis access. So thank you very much. Just like to acknowledge our team in Singapore General Hospital for the work that I showed. Thank you.
Thank you, Dr. Tenbusu, for providing us excellent review about hemodialysis intervention based on his extensive experience.
And now, the next topic, I would like to introduce Professor Wook Chung from Korea, who will present topics intra-arterial options for treatments HCC, TACE versus left TACE. Giáo sư Chung từ Korea sẽ trình bày cái bài về nút ung thư gan, TACE và left TACE trong điều trị cái ung thư gan. Chúng ta sẽ có cái hội, chúng ta sẽ sau các bài trình bày chúng ta sẽ có cái dành thời gian để mà hỏi đáp các cái thắc mắc, một số các cái bài giảng, 4 bài giảng của 4 ông giáo sư.
Thank you, Dr. Tong, for your kind introduction. the delay. Okay. Oh, not like this. It's reversed.